All right, thank you for an opportunity to update the progress of our trial. We've only recently started to really publicly discuss where we are after getting permission from the VA Office of Research and Development. So this is what's on the table. We have two excellent treatments. And in MDT conversations, I think we've moved beyond trying to describe the negatives of either and instead discussing the positives of either. If you sit down and really think about these two treatments, they're actually more similar than they are different, although they have a little bit of a different journey in the immediate post-treatment period. And as Rowena nicely showed, it's been difficult to measure a benefit of one over the other when it comes to long-term lung cancer control. Either the tumor has metastasized or not, and it's unclear if the local therapy can change that fact or its outcome. So this is what the radiation oncologist often encounters when an operable patient seeks to learn more information. And what I do is I just congratulate their physicians because they have mastered the evidence-based guidelines. I don't use the word gold when describing the standard of care. I just state that the preeminent evidence-based guideline leaders have preferred surgery whenever safe, but we just don't know which one is better. And I'm very proud that our team at UCLA is comfortable with this sort of statement. And we unanimously will say that we prefer surgery. We don't try to push non-surgical treatments because it's off guideline, and we try not to treat patients off guideline. So this is, I think, from an intellectual and academic perspective, is the why that we believe surgery is better. It begins with the history a century ago. And if you think about when it comes to breast cancer management, it took 100 years to move away from the radical mastectomy, which involves removing the breast, the skin, and the meat over the ribs, which is called the pec major. And it was 1870 that was pioneered, and it was 1970 when the NSABP B04 study showed that you do not have to do that extensive of a resection to move the needle towards lesser and lesser treatments for women with breast cancer. And I feel like that's where we are with lung cancer. So here is Evarts Graham, thoracic surgeon, one of the leaders in the field in the history of thoracic surgery at WashU, with his patient who was an obstetrician who traveled there for his lung cancer. And as soon as the surgery was over, he reported the results in JAMA in 1933. Leora Horn and David Johnson wrote a wonderful biography of the life of Evarts Johnson, and most of my information comes from this because it includes the follow-up. This picture actually is with the patient 25 to 30 years later, showing a testament that you could actually cure lung cancer, which by itself is a landmark finding. Here is the patient. He was 48 at the time. It was less than 2 hours with whatever technologies they used in 1933. I believe electricity was around, so I don't think they were operating with candlelight. Radon seeds were actually sewn at the stump to prevent recurrence. And this was at a time where cross-clamping the PA was actually very challenging from a hemodynamics management standpoint. It was actually node positive. There was a lot of controversy around the histology, and I think that they had additional pathologists look at the slides later on because the patient, again, had survived 30 years. But what's lesser known is that the next 19 patients, did not survive the surgery. So it was tough times. Radiation technologies at the time were very bad. In fact, there's a very sad paper written where there, I think, were several dozen radiotherapists who were radiologists at the time who actually died from electrocutions as they were trying to move away from radioactive materials as sources of radiation therapy to electricity generated radiation therapy. And so really radiation was off the table. And also Evarts Graham had written that, there had never been a case ever demonstrated to have cured anybody. So it was literally worse than useless. But nonetheless, in England, they were starting to see complete pathological responses in the 1940s. And by the 1950s, a randomized trial, the only one ever completed, actually was reported in Lancet in 1963. And this is well before the CT was developed. So basically, patients are staged by chest X-ray, and the radiotherapy was very mundane, large APPA rectangular portals through the chest. And because the spinal cord is there, we had already known by the 50s that you have to stop at 45 gray. You cannot go any higher. And here are the results, the 4-year survival rate. Surgery beats out radiation therapy. 58 patients, the same number of patients in the pooled analysis that Rowena just showed of the STARS Roselle. And I found this thing after I got involved in this space. I had never heard of this paper. So I found the wisest and oldest thoracic surgeons that I know, Jack Roth, and I asked him, say, Jack, does anyone ever quote this paper? He said, absolutely. This publication formed the basis of our belief that surgery is a better treatment through the 60s and the 70s and the 80s. And at that point, it had become such dogma that no one even referenced this paper before. But this is your level 1 evidence since that time, a half a century later, that defines why we believe and prefer surgery over radiation therapy. Now, I appreciate the slides that show that at expert institutions, surgery with good selection leads to very good outcomes and low rates of postoperative mortality. But, and I have a little bit of deja vu because I showed a slide like this not too long ago at an I-ELCAP meeting, and Dr. Al-Turki looked at me and said, you know, without having to raise his hand because he's Dr. Al-Turki, he says, you make it seem like we're killing our patients. And so I had referenced an article written by a radiation oncologist. So I did my homework, Dr. Al-Turki. I found an article written by STS. This is a little bit old, but ultimately it affirms what that slide had shown, which is the 90-day mortality is generally double the 30-day mortality. And actually the thoracic surgery literature itself says we really need to be looking at the 90-day mortality to get a better sense of basically how safe surgery can be. And here are the values highlighted in the bottom row of what the mortality rates continue to be, unfortunately, in the broader community, where 50% of lung resections are still being done by general surgeons. And of the other 50%, only half are being done by dedicated thoracic surgeons. The other half are being done by cardiac/thoracic surgeons. And so this is really the reason I think it's important to be pursuing non-operative treatments, including cryotherapy. I'm not so much of a fan of microwave, but cryotherapy, I think, also has a role, and I wish was discussed more, especially with these subsolid tumors. But back to Valor and this idea of comparing SBRT patients versus surgical patients. I don't think we're comparing the two treatments. We're comparing the patients. And when you see guidelines like this, it affirms that and even though they've evolved since 2023 to 2025, where now it's no longer a binary thing. It's saying that, you know, if the patient's talking with a surgeon and they're high operable risk, or the patient says, you know, can I learn about some other options? It's no longer inappropriate to at least refer to a radiation oncologist. But these guidelines still provide gatekeeping. There is a deliberate gatekeeping that leads to a concept that we've published about called confounding by indication. So by the indication alone, it is destined, self-prophecy, that the patients that are treated with SBRT are closer to death and therefore will be on a steeper slope on any sort of Kaplan-Meier curve. So summarizing, I hadn't seen Rowena's presentation before, but kind of like, I'll just show the Kaplan-Meier curves for many of the papers that she just discussed. So here's that 58 patient pooled analysis of the 2 attempted randomized trials. There is no typo here. You can argue about why surgery did this poor, but at the end of the day, I draw your attention to the blue line and ask, you know, how often can surgical outcomes surpass those SBRT outcomes? The team at MD Anderson, led by Jack Roth, everyone keeps talking about this as the Joe Chang study, but actually Jack Roth's name is first on the protocol, and he's a senior author. They took patients at MD Anderson who were in the thoracic surgery department, who were fit for a lobectomy, with PFTs in the 70 to 80th percentiles for FEV1 and DLCO. And instead, they registered them and enrolled them in a SBRT study. They call it SABRE down there, even though Medicare doesn't understand that term. And they propensity matched it to their patients at MD Anderson who had undergone a VATS lobectomy, in whom 10% were upstaged, as you would expect. All the SBRT patients had been EBUS and PET staged and clinical and 0. But 10% of surgical patients were upstaged. All of them got chemotherapy. And ultimately, neither the lung cancer specific or overall survival was measurably different. Rowena showed the updated ES lung study with a propensity matching. Those are your Kaplan-Meier curves. And then you also saw these. These, for me, are the four kind of higher quality propensity matched attempted efforts to really look at a true patient who could have been operated on instead. And as Rowena just showed, I thought I had the trick card in my sleeve, but she actually got access to it, which is 2 weeks ago, the update at the Astro meeting. And one of the residents from MD Anderson updates with 8.1 years of median follow-up. This is the revised stars of the 80 patients who were fit for lobectomy and still got SBRT. And I'm really curious about what's going on with the OS curve at 60 months. There's a lot of censoring happens, so the p-value, so the hazard ratio does cross to 1, but it does hint that maybe, a patient who wasn't operated on has a longer chance of living, or this is just a spurious finding. We do rely on statistics as kind of the arbiter of this. So the update on the study is this is our study design. So this is sponsored by the VA Cooperative Studies Program. And we have a very kind of well-established group equipoise between the disciplines that talk to these patients. And with 670 patients randomized with these stratifications, it's an anatomic resection versus SBRT. We've published our protocol if you want to look it up online. Only 5% after second consent and randomization refused their allocation. And these are the types of patients who are being randomized in this study with, again, high FEV1 and DLCO values. Almost none of them have ILD, high KPS. Our median tumor size is 2 centimeters and about 16% are in the 1B. This is per AJCC 7th edition, up to 5 centimeters. Most are peripheral, basically on epidemiology alone, and that's your histology. This was our presentation at World Lung just a few weeks ago. This is the typical scene between David Harpole and myself. He's talking and I'm listening because the guy is just a wealth of information. And he kept pointing to this part in the curve. And he said, look, if you look here at T minus 5 years from today, in September of 2020, all of the patients who were enrolled at that time and randomized have already been discharged from the 5 years of follow-up care. So this study already has a lot of power. So the question is, do we still really need 670 patients? And he taught me something I didn't know, which is that the CLGB study, because it also took basically 10 years to accrue, which is what Valor is on target for, recalculated their sample size. And in fact, they went ahead and reduced their sample size from 908 to 692 without having to compromise power, requiring only 76% of the initial plan. So in the Valor study, if we only need 76% of what we initially estimated, that's 510. We're basically at 470 plus, so we might actually finish enrollment next year, not having to go an extra 2 years as we currently predict. My final thoughts are this. So the VA CSP has a long history of completing difficult randomized trials, and this is a difficult randomized trial, even in the VA. A lot of advisors inside and outside the VA have helped get us here, and David and I are incredibly grateful to them. It is possible that SBRT may demonstrate higher OS. This is the sriracha spice that I promised you, Dr. Al-Turki. And ultimately, this is going to be a very rich data set for subset analysis to confirm when surgery is a better treatment for clinical stage 1 lung cancer, because if there's no difference between the two, I don't think that necessarily means that surgery won't help some patients more than SBRT could. Thank you.